Your cells rely on a constant, precise delivery of oxygen to survive. When a patient's breathing is compromised, diagnosing the root cause requires measuring exactly how much air their lungs can hold and how fast they can move it. This illustration shows a patient performing spirometry, the most common pulmonary function test. By measuring the volume and speed of inhaled and exhaled air, we can objectively evaluate the respiratory system. Administering this test requires 4 specific steps: screening for patient safety, selecting the right equipment, coaching the physical maneuver, and interpreting the resulting data. This character illustration breaks down the baseline lung volumes we capture during this process, like tidal volume and residual volume. Establishing these baselines is an essential requirement for clearing patients for surgery or diagnosing progressive lung diseases. Step 1 begins before you touch any equipment. You must rigorously screen the patient for contraindications. The test requires the patient to generate extreme intrathoracic pressure. Because of this force, conditions like recent abdominal surgery, pneumothorax, or unexplained hemoptysis mean the patient is strictly prohibited from testing. Even in cleared patients, the physical exertion of the test carries risks. You need to monitor them closely for syncope, dizziness, paroxysmal coughing, or bronchospasm. Bypassing this safety screen converts a routine diagnostic procedure into a potential trigger for a severe cardiopulmonary event. Step 2 is selecting the hardware. Spirometers fall into 2 distinct functional categories: primary volume measuring devices and primary flow measuring devices. This diagram shows a bellows spirometer, a classic primary volume measuring device. It physically captures and displaces the exhaled air to register the volume. This image displays a thermoanemometer. It belongs to the primary flow category, meaning it uses an external sensor to measure the speed of the air moving through it, then calculates the total volume mathematically. This photo highlights a handheld peak flow meter, which also operates under the flow measuring category, to quickly check the maximum expiratory rate at the bedside. Whether you use a mechanical volume collector or a digital flow sensor, properly calibrated equipment will yield the flow volume data necessary for a diagnosis. Step 3 is preparation. When preparing a patient for surgery, establishing their pre-operative pulmonary baseline allows the clinical team to assess their risk for post-operative complications. Proper positioning ensures maximum lung expansion. Have the patient sit up straight with their legs uncrossed and both feet flat on the floor, leaning slightly forward with their chin elevated. Ensure the patient has withheld their respiratory medications. Short-acting bronchodilators must be paused 4 to 6 hours prior, and long-acting bronchodilators are up to 24 hours. Next, demonstrate the test. Show them the exact posture and the sheer physical force they need to apply when exhaling into the mouthpiece. The machine simply records air movement. It cannot pull the air out of the lungs. Flawless physical coaching by the respiratory therapist ensures the data reflects the patient's true capacity. Now, initiate the forced vital capacity, or FVC maneuver. Instruct the patient to take a maximum inspiration, blast the air out as hard and fast as possible, and keep blowing until empty. This chart demonstrates an unacceptable maneuver. The red curve shows a slow takeoff caused by patient hesitation, which invalidates the extrapolated volume. This graph shows another common error. The sharp dips in the red curve indicate the patient coughed during the first second of exhalation, corrupting the volume calculation. This set of curves illustrates early termination. The red volume line abruptly flattens, indicating the patient closed their glottis or held their breath, instead of sustaining the necessary 6-second plateau. By identifying these specific visual errors on the screen, you can delete the bad attempts immediately and coach the patient until you secure 3 reproducible, acceptable maneuvers. Step 4 is interpretation. The primary metric we look at is the ratio of forced expiratory volume in 1 second to the total forced vital capacity, known as the FEV1/FVC ratio. This comparison graphic outlines how an obstructive disorder alters lung capacities. Compromised airways prevent air from escaping quickly. As seen on the right, trapped air causes a pathological increase in both residual volume and total lung capacity. This second diagram compares a normal lung to a restricted lung. A restrictive pattern indicates the lungs or chest wall have become stiff. As the downward arrows illustrate, the air simply cannot get in, severely shrinking the overall total lung capacity. These hand-drawn flow volume loops show how these disorders appear visually. The middle panels illustrate a caving, scooped-out shape on the expiratory curve, which is a classic indicator of severe airway obstruction. Determining whether a patient's lungs are actively trapping air or becoming mechanically stiff dictates the specific therapeutic interventions and medications the physician will prescribe. You now know the 4 distinct phases of the spirometry test. You can screen for safety, prepare your hardware, coach an accurate FEC maneuver, and distinguish the resulting disease patterns. This flowchart illustrates the broader diagnostic matrix. The initial FVC and volume data you collect serves as the mandatory starting point that drives this entire clinical decision tree. Your technical precision at the bedside ensures the medical team receives accurate, verifiable data. That accuracy is what clears a patient safely for surgery or secures them the correct diagnosis.